I'm doing this on your behalf. Are we together? Yes, I
Recording in
think that
progress.
this is a very important meeting and a very important conversation. I mean, for somebody like me who has had the privilege to work in about 10 of the countries on the continent and still counting, the quality of care gap is very telling and very overwhelming. So every effort that is gathered by experts and groups, like-minded groups and organizations, to come together to the same room to discuss the quality issues is worth encouraging and worth celebrating. We are learning over 100 people online, which is very encouraging. It is a very important opportunity for all of us. Now, the global conversation is how do we ensure that the culture and practice of quality across the continent is institutionalized or is sustained? Because in this part of the world, we have had a lot of support from the global health community, very huge support. And one that readily comes to mind is 5 years ago, the WHO supported 11 countries on what they call the Quality of Care Network. And this approach was to ensure that the quality practices were ingrained and countries were able to use quality to improve the outcomes of maternal and newborn health, and then also to cascade it across the larger health systems. Unfortunately, a lot of the gains are being eroded in most of the countries, and this is just less than 2 years after that significant support from the WHO. So a meeting like this is very encouraging, and learning from countries like Kenya on the efforts that are ongoing to ensure that the practices of quality are institutionalized are also worth celebrating. And let me quickly also mention that as a continent, it is not all gloomy. There are exciting examples across the continent. I mean, I mentioned Botswana, where I've had the opportunity to work and support their quality of care and development of their quality strategy. That in that country there is support from the Ministry of Health to support public health facilities to attain international accreditation. I agree that accreditation is not an end in itself, but it is a good start as far as ensuring that the culture and practices of quality is institutionalized. You go to Namibia as well, there is a very fantastic example as well in Namibia as far as implementing quality of care in Namibia is concerned. And Ghana as well, my own country. Just yesterday, we launched our second national healthcare quality strategy, which I was also privileged to be part of the team that developed. So across the continent, it is not all gloomy. There was the mention of the performance-based financing in Cameroon. In Africa, they've been that concept have been implemented in no less than 25 African countries. The concept of results-based financing and performance-based financing. The results have been mixed across the continent. So I'm sure we use this forum to encourage one another and to encourage ourselves, to encourage our governments as far as the efforts they are making is concerned, so that we shall all go. For me, I have learned a lot. As I sat there, I was typing a lot of the things that were being said. So it's a learning opportunity for me as well, and I hope it is for all of us. So let's learn, let's synergize the efforts, let's network. As was said earlier in the day, let's copy from one another, which is very important because it is the easiest way of learning. But as we copy and as we go back to our various countries and our various facilities, and we attempt to implement, let us acknowledge where we got the learnings from. At least it will encourage the innovators so that they will continue to innovate. And for we, the copycats, we will continue to copy. So that is, I think, that is how I would like to end. So let's encourage one another. Benchmarking, it's a quality improvement methodology, isn't it? So let's benchmark, let's copy from one another. But I add that again, that let us acknowledge the learnings and all the copying that we are making. I'm also from academia, and if you don't acknowledge, you are a thief, isn't it? I mean, it's, because plagiarism is stealing. That's the psychedelic name is plagiarism, but the blunt name is stealing. So if you copy from me and you don't acknowledge, then please, you are a thief. So I mean, let's not encourage stealing, but let's encourage copying and acknowledging one another as far as the learnings are concerned. And congratulations to Acquire and the leadership and that you have taken. And we are all happy to support the process so that together we will be comfortable that when you travel to Kenya and they put you in an ambulance and they are sending you to a facility, I mean, you can just wake up confidently and you know that wherever you land, you will get the quality of care that is required. Otherwise, and I end with this story of one of my mentors who was on admission. They had taken his blood sample for a lab test, and they were giving the sample to the wife to take to the laboratory. And he told the wife that, look, when you go, give the sample to this person in the lab. When you go and this person is not in the lab, bring back the sample. When the person comes to work, I will ask you to go back and give the sample to him. And it was the same example I was giving in the morning. If the food we are all cooking is nice, why don't we want to eat it? So that if the lab, why do you want a specific person in the lab to handle your specimen when there are 10 and 20 lab scientists in the lab? Why do you want a particular obstetrician to do your cesarean section for you when there are 110 obstetricians in a particular department? And why do you want a particular nurse to administer a medication for you when there are over 100 nurses in a particular ward? So I think this is food for thought for all of us, that if the food we are eating is sweet, why don't we want we ourselves and our relations to taste it? But we want to go and taste other foods for which we have made no contribution in their preparation. And that is the irony of a lot of us healthcare workers. So thank you very much.
Another round of applause for Elom. I think, Elom, you are a good storyteller. Yeah, but it actually is important that we always know we are potential patients, and the same way we give care on that ward or in that casualty. What if it was flipped? What if it was your child? What if it was your father? Do you need to leave duty to walk around the hospital escorting your relatives to every service point? Or you can tell them, just go, you will be taken care of. And so we are rewriting the story of Africa. We are telling stories so that when we reach there, we will remember that that's not where we want to go back to. Great, so allow me to have the next person to give remarks on behalf of MOH, Dr. Aisha. I know you won't tell stories like Elom. Dr. Aisha works with the division, is it division or directorate? The Directorate of Health Standards, Quality and Regulation. You're welcome.
Thank you very much, Dr. Lydia. Okay. Yeah. Good afternoon, everyone. It's my third time to speak with you again. Yeah, for me, I would say I'm very delighted to be part of this meeting and to even welcome you to our beautiful country. And we look forward to learning a lot from each other. We are having Dr. Kigen here. We have leaders in quality matters across African countries and acquire as a team. So we are very grateful to be part of this learning session, and as the Ministry of Health here, we are excited to be hosting you, and we look forward to learning from each other. Our division being the one in charge of, quality of care, we are very delighted, and you saw our passion, including Dr. Kandie, who was moderating our session in the morning. So welcome everyone, and we look forward to more interactions. Thank you.
Thank you very much. Another round of applause for the lady. Great. I don't know whether we know what Acquire stands for. BC, the full name for Acquire? Yes. The African Consortium for Quality Improvement Research in Frontline Healthcare. So the unique thing about Acquire is we are not doing something abstract just in academia, but we are where the patients are, where the healthcare workers are, where the healthcare outcomes matter. We know all those aspects. Research, academia is important, but something special is that Acquire's main interest around this subject is that it has to matter to the patient, and the front line is where care happens. And so when we hear about incident reporting, run charts, they're about real things. They're not theories. It's not in a factory, but in a hospital, in a health center, in a community, in theater space, in critical care spaces. So it is has that uniqueness. We call ourselves the last mile. When you have done all those policy and all those good frameworks, pathways, the last mile is that that child with an asthmatic attack will go through care process pathways that are true to quality care that they so deserve, they so need in a timely manner. So allow me to welcome Mary. Dr. Mary, are you there? We'll have Ruth Pal, or we will skip. Okay. So actually, Mary's, what I mentioned was on behalf of Mary. It is Acquire. Mary was to give comments. So Acquire has three people who are behind it. That is Dr. Mary Adams and Ruth Pal. Ruth Pal, you can wave. She's been the one welcoming us, and myself. We represent different skills, but we represent Africa on matters quality improvement. Allow me to go ahead and welcome our guest, but we'll do it this way. Dr. Keegan, we have around 8 countries represented here and many counties. So I think we'll start with the hosts. Nairobi County. Who are from Nairobi County? You can live, yeah, so we have several from Nairobi County. Thank you. And they represent public sector, private sector, their healthcare quality leaders. Some are their entrants, they've just come into the quality space. We have had about 700 teams or healthcare workers going through IHI Open School. And so we are truly grateful for those who've come. Then the other counties, we have Mombasa counties plus others. The other Kenyan counties, can you lift up your hand? Yeah, we truly appreciate. Largely we have Kiambu and Mombasa. Any other county I've not mentioned? Embu or Meru. And we have a large number online. I think over 200 have joined online. Actually, we had more than 8 counties among the teams that went through IHI Open School. Then we have our great guests that represent Africa. Nigeria, can you just wave? So we have Nigeria, and of importance, the Lagos State of Nigeria, and then the Society for Quality Healthcare Nigeria. I did not introduce myself as the president for Society for Quality Healthcare Kenya, and so I'm so happy that this Acquire Forum has enabled us to meet our counterpart in Nigeria. They are more established, more mature, but we are growing that journey. We are having our AGM this Saturday. So thank you very much, my sister, for coming. And for Lagos State, we managed to train about 7 cohorts for IHI quality improvement this year. So we have made such a partnership and a strong network. Then the other country, we have Cameroon. Where is Cameroon? Yes, thank you very much. So Cameroon belongs to the group that are related to us through the Christian networks. So Cameroon, with a hospital called Mbingo, together with the Christian Baptist Hospital Networks. They are an important group. Why? Because they are in a transition. I think as a country, they need more support in capacity building. And so we are willing and able to work with them on the quality improvement journey. Then we have, do you have Botswana? Great, so we have Botswana, one representation. I think we had 2 hospitals, two groups from Botswana who were in IHI. Then another group is Uganda, Dr. Herbert. Great, yeah, we have 2 representations from Uganda. They also were part of the IHI Open School, and so these are either their leaders or the participants. So truly happy for Uganda to be represented. Then Tanzania, there's Dr. Mugisha. Yeah, thank you very much. Dr. Mugisha also brought about 2 cohorts associated to the work he does. They also went through the training. Then which country have I forgotten? South Africa, how could I forget Dr. Lorraine de Kock, South Africa. So there's Dr. Lorraine and Dr. Tenza. We are truly grateful, and they've walked ahead of us. Like in their country, they already have some policies which we did catch up. They had their patient safety and incident reporting policy earlier than us. And I think there is much we can learn from each other. They are strong people in academia. Their HIV work is more established in QI. And so they've been able to integrate that into the rest of the system. When I see Violet and the work they've done in Kenya, in QI, and having the QI-ness in the HIV world go to the rest of the facility, it is really the work that Lorraine and the Urim Institute does. So we are truly grateful to have you here. They had, I think, several hospitals, about 60 participants for the IHI Open School. Happy to have you here. Any other team I've forgotten? Sudan, indeed and truth. I think we had 2 groups or one? We had 1 group. We are truly grateful. Southern Sudan or the Sudan? South Sudan. Great. Thank you very much for coming. I think that's our chief guest. That is the Africa that is here to learn with and from Kenya. And we are glad that next time we will also visit now Nigeria, visit Sudan. And so this is the beginning, one amongst the many that will come after this great gathering. Dr. Keegan, we are here for 2 days, and so it is just a short meeting, but we are exchanging a lot of notes. We are thankful for your office and for your team. Kandia has been part of the planning, Aisha has been part of the thinking, and Dr. Thomas and Dr. Irungu, so we are truly grateful. Without much further ado, allow me to invite Dr. Keegan. Dr. Keegan is the head of the Directorate of Health Standards in Kenya, and so he will give some opening remarks. Thank you, Dr. and you're welcome.
Thank you, Dr. Lydia. I don't know whether we were in the same class or the school after in university, but we were there together. Distinguished guests, colleagues, and participants, good afternoon. Good afternoon again. I think mine really is to come and join you as we have this important conference. The 2-day conference, I don't think it's the length of the conference, it's the intensity and what comes out in the conference. So I know this, the theme of this conference, it works. The theme of the conference is building quality improvement into African health system agenda. I'll just start with a small story about what is happening in Kenya. Kenya, we launched the UHC last year in October, and that has been our agenda. And if you look at the UHC agenda, basically the pillars were very focused, that are focused in almost every other country. The focus was on, we went a bit deeper this time. We wanted to do primary care. We also focused on digitalization, so there was a digitalization of the health system. We discussed, the other pillar was on human resource for health. Then, of course, there was health financing, and then health products and technology. We know those are the pillars. By the end of the day, to achieve UHC without quality, you're going nowhere. So in the last 3 years, we did, in the last 1 year, we've done a number of bills. We've done about 4 heavy bills to support that agenda. One of them was the Facility Improvement Fund bill. This reinforces the funds at the facility. The 2 was the Social Health Improvement Fund to increase our collectivity under the social health insurance. The 3rd was the Digital Health Act, just to try and ensure that we really get digitalized, everything around technology. And the 4th was the Primary Care Network, Primary Health Care Bill, to ensure that we'd establish the primary care networks for us to move as a country. So that has been done. So that's where we are as an agenda. Many questions, there are new bills, new things, introductions, so there have been challenges here and there, but the agenda moves. So as I welcome our participants, particularly I want to first welcome the ones from outside Kenya. In Kenya, when you reach here, we tell you karibu. Karibu means welcome. Karibu means, then what do you say? Asante, thank you. My colleagues from the counties, karibu pia. I also want to acknowledge the organizers for this conference, the Acquire team, the team from Kenyatta, and my team from the Ministry of Health for organizing this conference. So I'll just give a small few remarks as we move on. I have left that statement hanging about the bills. I've not finished it. I'll finish it at the end, but I've left it hanging. But you know that there are the bills and how the pillars for UHC. So let me just talk about quality a bit. We know that quality, patient safety is really important. We know that in the low and middle income countries, highest burden of death is due to unsafe patient safety. So we know that as much as we are saying it is the highest in the low, middle, and middle income, even the developed countries, they still have challenges of quality. So for us, as low income with our burden, heavy burden on an uncommunicable disease and infectious disease, we really need to improve our quality improvement. We know that between 5 and 8 million deaths are caused in the low middle income due to unsafe practices or poor quality of care. So as we move in, we really need to focus on what we need to do in terms of quality of care. You are the gurus, you know what happens in quality of care. And as you said, as the fellow from Ghana, Lemon, said that when you exchange, or when you do these exchange programs, or when you do this sharing, it is stealing knowledge in the right way. So we need to be sitting here and exchange for the improvement of quality within our countries and our institutions. When you look at quality of care, it's not just what we talk, it is what actually happens on the bedside. So as we go towards quality of care, we need to focus on one, a whole system approach. One from the boardroom to the bedside, from clinical to non-clinical. I remember we've done many things to look around quality of care, and you realized it's not just clinical. The support, the systems, which are in all these models that we do, are the ones that make sure that we have quality of care. Number 2, capacity of healthcare workers. It's not just enough to leave the university or leave the college. You have to keep learning, getting new capacity. You may have learned the best in terms of the best neurosurgeon, and you forget something about simple basics that improve the quality of care. So basically, a holistic approach to the healthcare worker, both in best practices, basic simple things that we need to learn as healthcare workers. Number 3, identifying best practices. I think that's one of the reasons as we are here. We exchange ourselves, see what is the best practices. Number 4 is fostering partnerships. As you can see here, we have a big mixture of teams, both from government, from institutions, from NGOs, we all want to work together to ensure that we improve quality. Use of technology to improve quality. If we used to write on papers, now we need to go digital, see where we are, and see what is changing and what can be used. If there are new equipment that are going to improve quality, let us use that. Finally, number 6 is building a community of practice. Let's have a community, and this is a community where we work together and we're able to get things done in the right way. So basically, those are the focuses that we have on quality of care. As I said, I had left a small part of my speech after the bills. So as a country, we realized that for us to be able to attain UHC, quality of care is paramount. And now we're really focusing on quality of care. This falls under my team of Kina Kandie, Aisha, Nanisa part of it, Kina Kutai, and many of us, whereby we are trying now to look at a quality of care bill. A bill that will eventually become an act and ensure that we have quality of care. It's not just enough to get that first certification, but how do we look at all these issues around quality of care? We have many things we have done. I'm sure my team, for the team from Kenya, has told you what they have done. But the quality of care bill makes it more of law to ensure that we improve our quality. It's interesting that just despite just quality doesn't just fall on that bill. There are many things around quality. I think in the last, last 2 months, we've had a lot of issues around human resource for health. That's another thing on quality. So we need to work on all these things so that we can be able to come up with something that will improve quality within the system. So as a country, we are actually emphasizing on quality. We have many things we have done. I'm sure Kinakandia will tell you the quality improvement things we have done, the KQMH, other things that we have. And others have talked about ISO, others have talked about several methods of trying to be able to get quality. But now we really must focus on that. So as we continue and as we focus here, let's really look at quality of care as the pillar to being able to achieve universal health coverage. So mine really is to welcome you for this meeting. We exchange. I've sat into one session. I hope I'll sit into another session. We also keep learning. And I really welcome you for this meeting. And I want to thank all of you for being able to reach here today. And the organizers and the team, the Acquire team, the Ministry of Health team, the KNH team, kudos for inviting all these people to be able to come today. So mine with those few remarks is just to officially open the workshop. Thank you.
Another round of applause. We are truly grateful for Dr. Kigen taking your time in your busy schedule to come here. It's a mark of commitment that as a country, we are committed to our people. And as part of the Brother Africa, we are committed to the continent towards ensuring that every other son and daughter of our soil has the opportunity to have the care that they need, that they deserve, that is indeed given in a manner that they feel respected, but that is also, we call it world class, because the world in Africa is the world in Africa. So we need to have our world class. Yeah, we are part of the global community. We learn and we bring home what works. What doesn't work, we adjust it. And at times, or always, we also innovate in Africa. Allow me to introduce all of, to allow us to ask us to come for a group photo, and then we will go to the next session as I ask that we can start connecting the next presenter. As we come for the session, maybe you can ensure that Dr. Irungu gets on. So we can come and just have a stand here for a group photo. Kindly.
Is ready? Okay. So good afternoon once again. Good afternoon, everyone. Dr. Elom Stable, good afternoon. Yeah, thank you. So we want to get right into the afternoon session. I know it's almost evening, yeah. So my name is Peter Mutanda. I come from the Society for Quality in Kenya. I'm a member of the Education Committee, and I'll be moderating this session, which should take us maybe the next 1.5 hours, if we can stretch it a bit. So again, I think we saw just before lunch that we were really running very late with our time, and we want to see that we can focus our energies back to the session, and then we try to see how much we can cover before we break for the day, and then we see if there's anything that can spill into a day two. So we have this in, it was meant to be a 3-part session, but I think we may just squeeze that into 2. One is that we'll have 2 presentations from 2 speakers. I'll introduce one of them before he speaks, and then I'll invite the next speaker after that. Then because we are aware that people just had a very good lunch, we'll want to put into some discussion. That will take maybe around 30 or 40 minutes. Then we'll try to see how much time we have for any kind of feedback. So can you confirm that? Okay. So maybe just before we invite Dr. Irungu to speak to us, the session that we are going to be discussing on, I will be touching on the whole aspect that really connects to what we've been discussing from morning, which is about the global patient safety environment, where we are in Africa as a country, Kenya, and globally, how this has evolved. And I think we all know in this room that as leaders in quality, patient safety is quite a primer when you start discussing about quality improvement. So I think we've all been part of this journey through many, many discussions. We are aware that there has been some very, very strong movements from the early 90s, a lot of awareness from WHO up to coming up with the discussions that came up around the year 2004 that culminated into a global patient safety action plan that was just released in 2021. And I think also that was against a backdrop of the epidemic, the COVID-19 epidemic that really swept the thinking about global patient safety, and the discussions have been very, very rife in all our communities of practice. So without much ado, I'll want to invite our next speaker. I wasn't here the first hour of the meeting. I don't know whether Dr. Kamau Irungu was formally introduced. He was. So can you just get us going with discussing where we are around global patient safety, and maybe just narrowing it down to our experiences in the country. So Dr. Kamau Irungu, if you can hear me, can you take it on? Thank you. Thank you so much, Dr. Irungu. I hope you can stay online for a few more minutes. We might need you for further discussions. So allow me to invite the next speaker who should be stepping up to the stage. And Loyce, before I introduce her, she's going to speak to us about infection prevention and control. Of course, IPC is one of the key things when you speak about patient safety. Loyce is based in Kenya. She works seconded to the Ministry of Health from CDC. She has a keen focus on quality improvement. She has been providing crucial guidance in enhancing IPC along the practice, working with the government, the authorities. She's an active member of the Society for Quality in the country as member of the Education Committee, and she has been offering her expertise in different forums across the country. She's also an executive member of the Infection Prevention Network in Kenya, and she works across different nationwide initiatives to advance IPC measures. Her passion is evident. She's a very active member of our society. She contributes quite a lot to our discussions, and she's going to speak to us about IPC, where we are as a country, and any collaboration that we are advancing as a nation. Thank you.
Good afternoon, everyone. All protocols observed. I want to thank our choir organizing team for inviting me here to speak about a topic that is so close to my heart, because I've been in it and I've seen what we have potential to achieve, and not to always feel like we are so much behind, because most of the literature shows how Africa, we are doing badly, and even some Asian countries. Just to quote the May 2022 report by World Health, it says that an effective IPC program can help reduce the risk of healthcare-associated infections by 70%. What are healthcare-associated infections? I'm sure most of us know. These are infections that our patients acquire while receiving treatment. And nowadays, we don't call them nosocomial or hospital-acquired, because we are providing care even in the doctor's surgeries, in the doctors' offices, in nursing homes. It's not just in hospitals. So wherever care is being provided, even home care, and a patient acquires a healthcare-associated infection, we need to take care of it. And why? Currently, we've known majority of those infections are even caused by antimicrobial resistant organisms. So they are difficult to treat, and those patients who acquire healthcare-associated infections, 1 out of 10, they die from that infection. That's how serious healthcare-associated infections are. And it is estimated by the same report that in the developed world, we have 7 out of 100 patients receiving care, acquiring at least one healthcare-associated infection. 7 out of 100 patients receiving care at any one moment, they end up acquiring a healthcare-associated infection. And that is worse in Africa. As I said, we always have data that is portraying us not doing well, but I believe, like for healthcare-associated infections, with QI implementations, we are going to get better and better. With all this leadership in this room, we are going to make sure that our patients don't acquire healthcare-associated infections, because majority of them are preventable. Majority of those infections, they are causing death, but they are preventable. So, What can I conclude this introduction with, other than saying we better be aware that healthcare-associated infections are among the most common healthcare complications. We were told in the morning by Dr. Lydia, we are potential patients. You don't want to acquire a healthcare-associated infection during your care and end up with a high bill, end up with a lot of stress, or end up in the grave. We need to do this together. QI can improve it. And so I'm here to share a story of my QI journey. A story of my QI journey. Sometimes story and journey are sort of related, but I want to put it that way. It's a story of my QI journey. And we can go to the next slide. So this is the outline of my presentation. I'll look at some basic information about QI, particularly in infection prevention and control. And I'll also highlight a few experiences. I'll just pick a few of QI initiatives that I've led in a few facilities in our country. And one will be on hand hygiene practices, surgical care for cesarean section mothers. COVID-19 found that myself and a team working with certain facilities, and we had to overlap the QI we were doing for basic IPC with the COVID-19, because we had seen QI working and we knew COVID-19 QI would help us to identify promptly the cases, be able to isolate them, and they get managed to prevent risk of transmission. And then I'll do a conclusion. Next. So just to introduce this, I want to say that a quality improvement knowledge gap has been quite evident among the leaders. And I'm glad we are here to discuss about QI and seeing how we can make sure that we bridge the theory and practice gap, because we have leaders who have knowledge on the principles of QI, but implementing the QI initiatives becomes a hurdle. So we need to improve the competency to effective designing, implementing, and sustaining the QI initiatives in our healthcare, because there is a lot of benefits, especially for infection prevention and control, QI implementation. These infections we are seeing, it is estimated like those patients in receiving critical care in our ICUs, almost half of them don't die from what brought them. They die from healthcare-associated infections, almost half of them. And so, as my boss, and sometimes it's so hard to speak after your boss has spoken, Dr. Irungu is my boss. I'm seconded in his unit by CDC Foundation. And he has alluded to Global IPC Action Plan 2024-2030. And we also have, WHO has provided IPC core components. The basic you need in a facility, in a nation, to say you have an effective IPC program. And these core components are 8. They were provided in 2016. And as countries, as Africa, if only we can implement those core components, we will be moving much in this journey. And it's not just waking up and trying to implement. We have to apply quality improvement processes from where we are to achieving that effective IPC program that can reduce healthcare-associated infections by 70%. Next. So on the QI for hand hygiene that I've picked out of some of my experiences, first of all, we need to know hand hygiene is important. Sometimes I talk to very senior people on hand hygiene, and they look at me like, man, you don't have something better to tell us about? Just washing hand. Hand hygiene is a procedure that is really trivialized. Some of us know even since we were young. Our mothers would pour water on our small hands, and we would be told to wash hands before we eat. And so hand hygiene is very important because it helps preventing spread of disease, and it reduces healthcare-associated infections. And of course, it combats emergence of resistant bugs. So many illnesses are known to be spread through contact. So if only we can perform hand hygiene, we will be preventing these many illnesses because they are contact transmitted. Name them. On top of the list, infectious diseases, majority of them are transmitted through hands. And these are the hands we use to eat, we use to care for our patients, so we need to keep them clean. And so how can we achieve this? WHO, again, provided some years back, looking at hand hygiene implementation, improvement of the compliance. They brought in what is called multimodal improvement strategy. If you do a baseline on how your facilities are doing, or your country overall, I know WHO sometimes ago did an assessment in Africa, and some countries were given their results as their specific results. And Kenya, we got a percentage of 3%, that out of 100 healthcare workers, or out of 100 moments, only 3% hand hygiene was being performed. That is not even equivalent to one hand, because I could consider 2 hands as 100%. So one hand could be, if you have washed one hand, could be 50%. But now this is 3%. It's not even one joint. So we need, it's an area that is very important, and we need to focus on it, because sometimes I tell people hand hygiene is the mother of IPC, infection prevention and control. If we can succeed in hand hygiene, then the rest will start falling in. And the multimodal improvement strategy is so much to help us in applying quality improvement in a stepwise and more focused way. And the first component of multimodal strategy is build it. Build the system. Do not tell people in Garissa County Hospital to perform hand hygiene, and there is no water flowing in the taps. There is no soap provided. So we need to build the system, and that is the starting point. Build the system, then come back and teach it. Teach about that initiative, talk about it. Teach the healthcare workers so that they can participate effectively in the implementation. And then check it. You have to monitor. We were told there is no QI without data. We have to monitor and evaluate how we are doing, how we are performing, how we are implementing these components of QI, these interventions, and get to know which direction are you in. Are you making change? And if you are making change, can you check if this change is improvement? Because sometimes you might see change just because you have started looking at a situation and you start seeing difference in the numbers, and which may not be change. It might just be increased ability to identify cases. Then when you check it, you do sell it. Sell it. That is, you put in place reminders, put in place communications, remind people about that initiative. Like in hand hygiene, remind people to perform hand hygiene. Have posters next to the hand washing sink, and so on and so forth. There are many ways of enhancing this. And this, you keep improving the situation. And finally, make it your culture. Quality improvement. If you're talking about hand hygiene, let it be institutional and individualized initiative. Let it be their word of every day. The institution, when we talk about institution, we are talking about leadership. Support this initiative. Support individuals who are championing this particular initiative. Next. And so this was an initiative on hand hygiene that we undertook for over a year, 2017, 2019, and actually we started with training. We trained healthcare workers, both professionals and support. We trained on basic IPC. We also trained the committees for infection prevention and control on quality improvement, and then we trained them on principles of teaching and learning so that they are able to handle the adults they are going to deal with in a safer way. And so we had these two facilities that were doing very well. They started very low. One had a baseline of 23, the other one had a baseline of 3, and they walked the journey. And as I conclude, I'll be talking about some of the challenges. As you can see on graph on my right, there are 2 months there, January and February. There was a healthcare worker strike. The other one, the first graph is up to December. It also had those 2 gaps. So, but we can see. But of most importance, every drop we had, the team was able to relate it with something that was happening. The graph on my right showing, I think that's the month of, there's one reading 21% in August. When this project started, we discussed with the county and the facilities, and we talked about what they need before embarking during the introduction meeting. But by the time we were almost kicking off, after training and doing baseline assessment, there were no supplies. There was no supply for hand hygiene supplies. So the CDC had to facilitate procurement. And so for the first facility, they were able to replenish the supplies before they were finished. But the second facility didn't replenish. So as the supplies were getting depleted, they were seeing the drop. And finally, the drop was evident because the hand hygiene procedures procedure method that remained was hand washing only. And that's how they ended up with the 21%. And when the team took this to the CEC, she was shocked and she started making calls at that moment. And the procurement was done and they started picking. And we have a success story about hand hygiene in those 2 facilities, because even when COVID struck, most people went there to find out how they can improve their hand hygiene compliance in their facilities. Next. The other one is on HAI, healthcare-associated infections, surgical site infections in cesarean cases, where the teams were trained and supported on surgical antibiotic prophylaxis use. We know before surgery, there should be some antibiotic administered to reduce the risk of healthcare acquired infection, which in case a contamination happens during the surgery. Of course, blood sugar check, because we know sugar may interfere with healing process and cause infection. Hair removal, hair should not be removed for whatever surgery unless it will interfere with the surgery, because hair removal, shaving increases the risk of healthcare associated infection. And of course, compliance with surgical care bundles. What are bundles? These are interventions that are researched and found to work. For example, in surgical care, the performance of a good hand scrub by the surgeon before they start surgery is one of the elements. But alone, it can't prevent better. It needs the surgical antibiotic prophylaxis to be added. It needs hair removal to be considered. And it needs blood sugar. So all these are elements that when combined together and implemented, they increase the safety of the patient from acquiring an infection. So when it is one, it can work. But imagine like that bundle that is there, that is on the picture. If you light fire on it, it will have better fire. And more than if you are lighting one after the other. So that is the essence of using care bundles. Next. So this is to share the success of that particular QI initiative, where we are seeing one facility is blue, the other one is orange. And we can see sometimes it's just like children. They don't perform the same. Even when you put efforts, similar effort, equal efforts, they don't normally perform the same. But sometimes it's because of the leadership. When you have a facility with very good buy-in, you are able to implement your QI initiative comfortably and successfully. So in 5 months, that's what the data was like, where we saw some ups and downs, but they say it's until about 6 months you are able to tell which direction your QI is going. So we were almost there, and in the reduction of SSI rates in those two facilities. Next. COVID came. When we were in the midst of other QI, and we decided to jump in and focused on triaging. We did hand hygiene, we did use of mask, we did monitoring of screening of healthcare workers as they came into work. If they had coughs, if they had colds, they would be released to go and observe themselves. And inpatient screening, because we realized we kept on hearing of incidences where patients would be admitted, and then later in the same ward, we end up having several patients having COVID. So we started screening. We developed, we came up with indicators and developed the tools on what to be monitored. And of course, isolation practices. And we went ahead and asked ourselves what we wanted to implement and what we were trying to accomplish. And of course, how we were going to identify change. And we followed the PDSA cycle to be able to monitor and keep improving ourselves. Somebody asked in the morning, if a tool you are providing, it's not working, what do? Sometimes you just, as it was said, you go back to the drawing board. But sometimes you have, when you're doing your root cause analysis, because those are the preparations, the planning part of it, you do a root cause analysis. You might come up with more than one intervention. So you prioritize the interventions. Then you pick one and start running with it. You consider, is it a high volume, is it a high risk, and all those that will make it be picked to be the first one to be implemented. Because even for surgical site infections, you don't pick all the procedures. You identify a procedure that you'll be able to kick off with, and then do the PDSA. And if an intervention is not working, you can bring in the one that was next priority and see whether the things will start changing. Next. So for COVID-19 Quality Improvement Initiative, a lot was done, and it started with centralizing the triage services by ensuring patients come in, or people come in through one door, and they are all screened, and then those who are coming for treatment, they go to the triage area so that they are taken care of in case they have any signs. There was prompt identification of cases, and there had to be some provision of some triage structures that were missing. As you heard in the morning, our challenge is structures. And some of the structures we have in place in our facilities are too old because they were made many years, they were constructed many years ago without IPC in the mind. You will find a ward with one sink, and it's a ward having 50 beds with the patients. And in our situation, I know COVID came and helped us learn how not to make our patients share beds. So we are getting better. We used to have, before COVID, patients were sharing beds. You have over around 200% bed occupancy and one sink at the corner. You even wonder how many staffs will have courage to walk all the way. So that is the infrastructure that we are saying. Even with QI, we will embark in improving. So it's quite congested. My graph is a bit congested, but it just shows you a few of those key areas we were looking at: the triage, patients, inpatient screening, healthcare worker, and how they were scoring in that. Next. In conclusion, what worked? We saw leadership support. And as you have seen, data in hand hygiene, one facility, the leadership was not very supportive, but also at some point there was a lot of transition whereby you find you are speaking to one CEC today, a month later they are not there. In the facility, one CEO or medical superintendent, and in the next 2 months, they are not there. So it was a bit hectic, but we managed to gather some data and guide the practices. And I said this, the first one on hand hygiene started 2017, and I can tell you to date, we have an eco program for training healthcare workers. And the people who participated in that initiative, we still hear them being picked to share their experiences, meaning they are doing a good job up to today. So the partner who was supporting is no longer there. 3 years back, it ended 2021, 2020. And today they are still continuing with a good job. Because of leadership support, there was a lot of training and education. We did monthly with the Ministry of Health team, we did monthly mentorship visits to those sites. We spent a whole week with them, working with them in their wards. We would go like 10 of us, and we are in different wards, mentoring them. So mentorship means a lot, especially in QI. Teamwork, the healthcare workers learned to work together. Whether you are a surgeon, whether you are a pharmacist, a lab person, they were there as a team. Effective use of resources was found, and I can tell you one facility they were renovating, one ward. And the issue of the infrastructure came in. And they were able to change their taps from hand-operated to elbow. And from there, the next ward they renovated, they put elbow. They made it their innovation of changing that. Of course, we were rewarding the performers, and it bore fruits. The challenges, like I said, knowledge gap. There was also the issue of data collection, the knowledge on data collection. And of course, lack of induction. The new healthcare workers and students, there were no induction programs, which one, by the time we realized that was a challenge, they were initiated, so that whoever comes in picks with the culture of quality improvement. Next. I leave you with this quote. If your actions inspire others to dream more, learn more, do more, and become more, you are a leader. Thank you.
Another round of applause. Thank you very much, Loyce, for that, reminding us not to trivialize hand hygiene, yeah? Because we know how it was very, very significant during the last pandemic, global pandemic. So I know we are so spent on time, but we want just to shake it a bit. So I want to ask that we spend another extra 20, 25 minutes, if you don't mind. I know there's a dinner and people want to go and change into their dinner dresses and suits and all that. Yeah, we'll have time. So, can I request that I want to put you into 7 groups, but because we don't want to move a lot of stuff, I just want to combine some of the tables so that we have only 7 tables. Yep. So can I request, because you are few, sorry, maybe the table with the lady with the blue shawl or blue sweater? Sorry, I don't know the names. Can I request that you, oh yeah, sure. Can you move to Dr. Edna's table, please, if you don't mind? Dr. Labisi, and your friend, can I request that you move to the table behind you, if you don't mind? Thank you. That would be how many tables now? 1, 2, 3. Dr. Elom, I can see you are alone there. Can I give you company? Join the table just across? Yes, if you don't mind. This 1, 2, 3, 4, 5, 6. So there was a WhatsApp group that was created for this forum. I'm sure many of you might have seen it and maybe just joined it. We want to have hard copies? Yeah. So I think just like Dr. Irungu was telling us about the Global Patient Safety Action Plan 2021-2030, it has the 7 strategic objectives. So we want to focus on the 7 strategic objectives. We also know there's a matrix that defines the specific areas of strategies for the 7 objectives. But we want just to focus, each table will give it 1 strategic objective to focus on. So Dr. Lydia will help me just identify table 1 to table 7, then go by that numbering. So table 1 will work on the strategic objective number 1, which is making zero avoidable harm to patients, a state of mind. Then table number 2, you will focus on strategic objective 2, which is about building high reliable systems. And we spoke about that again during Dr. Irungu's presentation. Then table number 3, please look at what kind of safe clinical processes that you have. Table number 4, you look at objective number 4, which is how we engage and empower communities and patients that receive care in our healthcare systems. And then number 5, we're focusing on the whole aspect of skill enhancement for the healthcare workforce and how that contributes to the design of better healthcare systems. Then number 6, you look at the whole information knowledge management that relates to patient safety. Then number 7 is about how we've had come up with multi-sectoral partnership and forging collaborations around patient sector. So I think in the randomness of things, I know in every table, in each table you have either a government or a non-government actor. You could be having an academic institution on that table. You could be having a facility that provides healthcare. You could also be having, I think those are the main key stakeholders. You're either a partner, a government, a healthcare facility, or a stakeholder in the patient safety journey. So we want just to look at where you are. Please just identify your institution. If it's an organization, just write organization. Where are you in that particular strategic objective? So if you can take 15 minutes, I think that will be okay. Then we'll come back and guide on how we'll present this tomorrow. Is that clear? Sorry, is that clear? Or do I repeat the instructions? Rhoda, is that clear? Okay. Okay, the 7. Okay, great. Or the matrix. Okay, great. Could someone help with that? Yeah. So in case you are on the WhatsApp group, the template was shared this afternoon by Ruth Pal. You can always check on that. Remember, you're only focusing on one strategic objective for every table. So Dr. J, your table number? 5. Thank you. Dr. Labisi, your table number? 6. Rhoda, your table number? Yeah? 3, okay. 1, 2, 3. Is someone helping to project that template? Okay.